Good morning, everyone, and thank you for coming. I am honored and thrilled and excited to be here for two reasons. One, post-intensive care syndrome is something I'm very passionate about. And second, because it's the Max Harry Weil Memorial Lecture. As Kent said, I have had the honor of being mentored by Dr. Weil very early in my career at the Center for Critical Care in Los Angeles. It was a mecca for training and research and cutting-edge technology and practice. The multidisciplinary team care was modeled that embraced and modeled compassionate care for patients and families as well. That's the good news. The bad news is the standard of care in that unit was so much higher than anywhere else in the country. Remember, back then, most people hadn't even heard of what an intensivist was. When I went around to other places, it was very hard for me to stomach the gap. So I decided to do what I could. And at that time, we did not let nurses work in ICU without training and without precepting. So I devoted my career to trying to make them as good as I could. So if the physicians weren't trained, at least the nurses had a good training and background. Dr. Weil was also a founding member and early leader of SCCM, so he got me involved with SCCM very early as well. I think I've been a member for 40 years and very quickly became committed to promoting their mission and vision. I have no disclosures. So, as I said, in the past 10 years, I've become very, very committed to advancing the practice and care of patients with post-intensive care syndrome. So I'd like to talk first about the truth about the consequences of critical illness, and then right care, right now, and later. So I'll set the stage, and then I'll describe what we know about the problems, the risk factors, and incidence of PICS. And then we'll talk about some of the strategies we've been identifying as a way of dealing with it. You can imagine in 47 years of critical care nursing practice that I've seen a lot of exciting changes that have allowed us to keep patients alive longer. And we proudly discharge millions of patients home to communities every year. And although we've always known our patients have a long, hard road to recovery, it's only in the past 20 years that a growing body of literature has informed us of how remarkably common and devastating the long-term consequences of critical illness can be and how much our patients and families can suffer. But although it was a source of moral distress for us and very disturbing, to our credit, we swung into action and rapidly began identifying risk factors as well as some strategies that we can apply. Now, although the critical care community is rapidly becoming aware of post-intensive care syndrome, the outpatient community and patients and families largely are not. And after all, they're the ones that are more directly affected by it. So they don't come to our meetings, they don't read our literature, they don't follow our research, so that we can't expect them to know about PICS. It's our responsibility to increase their awareness and to work with them to improve the care that our ICU survivors and families get. SCCM has long been very good at collaborating with critical care organizations in the United States and around the world. They do that very successfully and have for a long time. There have some emerging concepts that helped us push the ball a little further to include the non-critical care community. One is the emphasis that's growing on family-centered care. Second is the focus on safe handoffs and transitions of care. And then also, as you heard in the initial presidential address yesterday or Sunday, we're now defining critical illness as not just the stay in the ICU, but what happens to our patients pre and post discharge. So in 2008, when we proposed that SCCM convene a consensus conference of stakeholders involving lots of non-critical care organizations, although it was a big step for SCCM, they appreciated the need and approved it. So we held the first one in 2010, and there were 14 organizations represented, and in 2012, we had 21. The results were published in Critical Care Medicine. So invitees included not only SCCM and international experts on PICS, but also representatives from JCAHO, NIH, and several national professional organizations of primary care, rehab medicine, physical therapy, occupational therapy, long-term care, palliative care, speech and hearing, caseworkers, social workers, healthcare systems. We invited the VA and Kaiser to send a representative. And importantly, we had 4 patients who had experienced PICS, and 2 of them were also family members of ICU survivors. So what we did in the 2-day conference is the first couple hours we had the experts present what we know about PICS, and the patients describe their experience. And then we spent a day and a half brainstorming, everybody giving their different perspective and ideas and identifying roadblocks so we could come up with an action agenda to increase awareness, promote better care, and foster more research. It was clear to us that although we're increasing the awareness amongst the group of stakeholders, we also needed to focus on increasing awareness in ICU patients and families. The representatives from the organizations went back to their organizations and peers, and through their publications and presentations and initiative are promoting the agenda. But we needed to do things to inform patients and families. The more they know, the less they fear the unknown. And when something new happens to them or they don't recover as fast as they think they should be, they don't get scared. And they realize they might need follow-up care and referrals for special services. Basically, they need to know they're not alone and we have not abandoned them. To this end, we have now a definition of PICS on Wikipedia. We had our 4 patients with PICS describe their experience on videos, and they're now posted on YouTube. And we have a new brochure on PICS that's posted on SCCM's website. There are 2 very good websites with information not just on PICS, but on some of the strategies we'll talk about to deal with it. One is John Hopkins' website, OASIS, which stands for Outcomes After Critical Illness and Surgery. And there's also one called the ICU Recovery Network through MedConcert. Something we're all very excited about is SCCM's Thrive initiative. Dealing with PICS and promoting better care for PICS has become a very high priority for SCCM. And through the Thrive initiative, they're awarding grants to those doing research to further accelerate recovery and improve patient family support, as well as establishing peer-to-peer support systems and groups. Well, I'm sure you know, post-intensive care syndrome is defined as new or worsening impairment in physical, cognitive, or mental health status that arise and persist after hospitalization for critical illness. I'm going to give you a description of the components, but as you'll see as we go through this, there's a very wide range of findings in the literature, partly because of the patient population studied, the comorbidities, the psychosocial situations, the care delivery systems, the measurements tools used, and when the measurements were made, which could be anything from a month to even years later. The physical consequences include 10 to 60% of our patients who undergo mechanical ventilation have difficulty with ADLs a year later. 25 to 50% of those who undergo mechanical ventilation for more than 7 days, 4 to 7 days, and 50 to 75% of those with severe sepsis develop ICU-acquired weakness. And 85 to 95% of those with weakness still have abnormalities 2 to 5 years later. The cognitive consequences are problems with memory, processing speed, planning, problem solving, and visual spatial awareness. 30 to 80% of our patients have cognitive impairment a year later, which can improve in some but not all. 25% of those with ARDS still have impairment 6 years later, and in those over 65, it can exist up to 8 years later. The psychosocial consequences, 10 to 50% of our patients have symptoms of depression, anxiety, and sleep deprivation that can last for months to years. And 10 to 50% have clinically significant symptoms of PTSD, which can still be present 8 years later. You can imagine all of this leads to socioeconomic consequences. Patients report a lower quality of life that can improve slowly, may return to baseline after several years. 50% of our patients, though, do require some caregiver assistance a year later. That can vary from a little help with ADLs to full care. 50% of patients with ARDS, and in this study, the median age was 45, had not returned to work in a year, and 33% never did. Less than 10% of our patients who have undergone mechanical ventilation for more than 4 days are alive and completely independent a year later. There are other potential consequences: decreased pulmonary function, dyspnea, loss of appetite, difficulty swallowing, immunosuppression, joint pain, stiffness, discomfort, fatigue, sexual dysfunction. And clearly, our patients have a higher mortality rate post-discharge, higher readmission rates, and can become chronically, critically ill. All of this I've begun to think of as the cost of living. Our patients pay a huge price for surviving critical illness. We currently discharge about 5 million patients from ICU in the United States alone each year. And with the demographic changes, this is expected to increase. That means the impact of PICS will also increase unless we can do something about it. PICS will also have an impact on resource utilization and the cost of care. So, that's the good news. We have some things we know we can do. And although the research is young, many of these things, as you'll see when we go through them, are things you already do for well-known and long-established reasons. And now that we know they help with PICS, we have another reason to make sure we do our best to apply them in every case. Certainly, we can try to reduce the risk factors. We can't do anything about the age of patients, but we can reduce immobility, number of days on mechanical ventilation, the ICU length of stay, heavy sedation and delirium, try to prevent sepsis and ARDS, hypotension and hypo and hyperglycemia, and hypoxia. And as I said, you can see these are things we're already trying to prevent and minimize. We really need to just decrease all the complications of critical illness that can lead to these. One important strategy is early mobility programs. We know that early mobility started right after admission is safe for most of our ICU patients. It's been shown it can decrease the ICU and hospital length of stay. It can shorten the duration of mechanical ventilation. It can decrease weakness, delirium, depression, anxiety, improve their functional status, as well as decrease the well-known problems of immobility. All of these are risk factors or can impact the incidence of PICS. Those of you who are trying to apply this in your own institutions, though, realize it's difficult. First off, it's hard to write the particular policy and procedures, guidelines, because we don't know the exact timing, type, duration, and frequency. And there's quite a need for staff education and training. They have some fear of potential consequences we need to overcome because it turns out they're very low incidence. They have pre-existing beliefs and practice patterns. It's time and resource intense, so that it may take a real change in culture to successfully adapt this across the board. Another logical strategy, you would think, would be to have post-ICU rehab or follow-up clinics. And although the research is ongoing, it's difficult still to understand exactly who, what, where, when, and how we should design these programs. But now that we know PICS exists, we're really ethically, professionally, morally responsible to recognize and address the potential for these ongoing, largely unmet needs. These are fairly common in the UK and throughout Europe, but not yet in the United States, although I hear there are many more popping up recently. So the effective strategy for your facility might vary from those of you who work in small community hospitals to just somebody making follow-up calls to make sure they're getting the care they need and get them the proper referrals, to, in larger systems, a full clinic that offers all the assessments and services the patients and family might need. Recently, there was a study that showed that early psychological intervention can help. When they had psychologists establish programs in the ICU that supported, counseled, and educated patients and families on coping and stress reduction techniques, it actually decreased the incidence of anxiety, depression, and PTSD. It was cut in half. This also might require some follow-up calls and maybe discharge post-ICU appointments. We also need to provide a more healing environment, not just for the humane reasons and to decrease the traumatic, stressful event that the patient and family experience, but it also can decrease delirium, agitation, and anxiety. We can promote sleep. We can enhance patient comfort with all of our little tricks. We can decrease noise and adjust the patient's room temperature and lighting and drafts to their comfort. We can make sure they use their glasses and hearing aids when appropriate. We can have the families bring familiar objects from home. And we can just basically show them how much we care, show them our compassion. If we decrease delirium, that's been shown to decrease the risk, excuse me, of cognitive impairment and PTSD in patients post-ICU. We know our pharmacological interventions for delirium, for pain, anxiety, and agitation can actually increase the risk of delirium. And so these non-pharmacological interventions become more important and more effective without the burden and cost. It's just part of being an intensive caring unit instead of just an intensive care unit, and part of incorporating palliative care principles into the care of all of our patients, not just of those at end of life. one thing I've been harping on for a very long time is how the art of nursing makes a huge difference. And we don't have a way of measuring this, but I'm sure it impacts a lot of outcomes that we study in ICU patients. And let me give you an example. At one end of the spectrum, and I bet you can think of colleagues you've watched, worked with that might fit into either of these two ends of the spectrum. But at one end, in patients who are less responsive, you have a nurse that walks in, flips on the light, talks to their colleagues in the hallway, treats the patient like an extension of the bedside equipment, isn't gentle when they turn them, doesn't talk to them at all, doesn't engage, and leaves. At the other end of the spectrum, you have a very caring nurse that goes into the room and first engages with the patient with touch, eye contact, asking them how they are before they go through all the tasks that they need to do. And while they're doing their tasks, they're very gentle, tell the patient what's happening, even when they're not that responsive. They assess their comfort needs. They assess the environment. Do you think having one or the other of that type of nurse would make a difference to some of the outcomes that we measure? We don't have a way of measuring it, but I wish we did. Another very effective strategy is ICU diary programs. These are patient diaries kept for the patient by the family and staff. And it takes some instruction. You probably need to have a notebook with an introduction of why it's of benefit, what they'll use it for, how to use it, what entries might include. And then the patients and families, the families and staff, write entries on what went on with the patient, what the patient's response was, what their feelings and responses were, just anything that they feel might be appropriate. And if there's a camera provided, they can also include pictures. We know our ICU patients have more false recollections and delusions and hallucinations about their stay in the ICU. So that after they're discharged, if they sit down with somebody, hopefully somebody from critical care who can give them the context and answer their questions, read through it, it helps them understand what really happened to them. ICU diaries have been shown to decrease patient anxiety, depression, and PTSD post-discharge. They also have been shown to decrease PTSD in families. They're widely used throughout Europe, but just beginning to be started here in the U.S. Another thing that's been suggested is to have a functional reconciliation checklist. And this is something that a checklist that goes through the continuum of care that describes the patient's physical, cognitive, and mental status to make sure we're addressing their ongoing needs, that they're progressing. And it's very valuable also at discharge because it identifies the need for ongoing referral and care. It's not been studied yet, but it seems like it would be a fairly useful tool. We don't know the best assessments to use, and the pre-hospital status of the patient might be difficult to determine. We can also use the PAD A, B, C, D, E, F guidelines. And I'm sure you're all aware of this, but if we can decrease pain, agitation, and anxiety, we can also, and delirium, we can also decrease the incidence of PICS. So A is for assessment, prevent, manage pain. B is for both spontaneous awakening and breathing trials. C, choice of sedation and analgesia. D, delirium assessment, prevention, and management. E, early mobility and exercise. F, family communication. But I'd like to add a little more to it. I've been fiddling with this. For F, we could add follow-up referrals, functional reconciliation. For G, we could have good handoff materials and communication. For H, we could have healing environments. For I, we could have ICU diaries. So there's quite a list of things we need to think about starting. Risk factor reduction, early mobility programs, post-ICU rehab and follow-up clinics, early psychological intervention, more healing environments, ICU diary programs, functional reconciliation checklists, and the ABCDEF bundles. This is a dream I have. I dream of the day where we'll have enough research on some of these interventions that we'll have a bundle of strategies for post-intensive care syndrome, that if we apply them every day in every patient, all of them, that will reduce the incidence and impact of PICS. Now, what about PICS in families? This extends our current model of patient family-centered care. It just builds on the compassion and caring we've always felt for them. We understand that they are an important link to the patient's past and their values and beliefs, as well as an important resource to care during the ICU stay and a bridge to their future care at home. So addressing PICS in families is not only a humane and responsible thing to do, but if we take better care of them, then they'll better be able to take care of the patients at home. We know some of the risks for PICS in families. It's higher in women, it's in patient spouses, when patients are younger or at a higher risk of dying, in those with less education, in those involved in decision-making roles when it's not the preferred role for them. It's lower in those who get more support and information during the ICU stay, as well as from their community and family. Look at the incidence of PICS in families. 20 to 75% suffer from anxiety, 8 to 42% are depressed, and a third of them are taking meds for anxiety and depression when the patient is discharged. 8 to 33% have symptoms of PTSD that can persist for years. It's higher when the patient was a child or the patient died. They can also experience complicated grief or exacerbation of their own chronic health conditions. All of this can challenge the family dynamics and relationships, as well as their financial security. So what can we do to decrease PICS in families? Obviously, we need to work hard to promote family participation and presence and participation in care. We need to establish good teamwork between the family and staff, have frequent and understandable communications and conferences, and very active listening. I'm sure you all know a lot about how to establish good family-centered care. We can create an ICU diary program. They help families as well. We can establish psychological or psychologist support and intervention during the ICU stay. This has been shown to help families as well. We need to have written materials available for them on what resources you have in the community or on the websites. We have to teach them the skills they need to care for the patients at home. And very importantly, we need to encourage them to take care of themselves as well. You can see this requires collaboration. The caseworkers, social workers, and discharge planners are key to this process. And we need to work more closely with those that provide them their primary care. We also need to continue our efforts to promote the awareness and education of those caring for our patients and their families in the outpatient community. You can do this locally in those in your community that you interact and refer to, but we also need to do it as a society to work with other national organizations to promote better care, more awareness, foster research. We're not responsible for providing the care our patients get, but we are responsible for informing those that do. And if it's not us, then who? I know this all adds to your role at a time when we're stretched, but ultimately our success as critical care providers will be judged not just by survival alone, but by what patients and families really want. Survival is not the end point for them. They want to return to the highest quality of life. They want to thrive. And I know that's ultimately what we've always wanted too. Anything we can do to mitigate and address PICS can have a very high impact on their goals. We have to do something. But I know you. You can. You are. You will. I admire you for everything that you do. So, thank you. Thank you.